Hello and welcome back to the APAC recap of CAPP 24. My name is Laura Ross, current president of the Academy of PAs in Cardiology, and thrilled to have Greg Duck here to talk a little bit more about his session during CAPP 24. Greg, tell us a little bit about yourself before we dive into your topic.
Yeah, absolutely. My name is Greg Duck. I'm a cardiology PA. I've been a PA for about 7 years, all of them in cardiology. And currently, I work out of a county hospital. So many of our patients are indigent, underfunded, very, very sick. One of the lectures I gave more recently at CAPP was a lecture on methamphetamine-induced cardiomyopathy. This is something that we deal with a lot here where I work in Fort Worth, Texas.
Great. Well, what did you present that PAs and or nurse practitioners could start doing today for this patient population who might be suffering from a cardiomyopathy?
Absolutely. So I think number one, we say this phrase a lot, but you got to really understand where somebody's coming from. You need to understand what quantity of amphetamines they're using, how regularly they use, why they use it. These are all very, very integral into knowing how you're going to tailor your approach moving forward. And what I mean when I say that is, if you're actively exposed to a stimulant and you're tachycardic on the basis of that stimulant, that's going to impact how much beta blocker you put somebody on. Because at some point, if they're currently using and then they decide to quit maybe abruptly later and you have them on a significant magnitude of beta blocker, their heart rate might take tremendously. They might feel terrible. And then their impression of being on medical therapy is that it's just terrible and it's going to make me feel terrible. Why should I be taking this? And so having those conversations outright is going to do you a lot of favors. But really, I think, number one, knowing somebody's background, how much they're using, when they plan on using, knowing the core concepts of FRF GDMT, that's very important. Obviously, I think we've all heard that a lot at this point. I hope so. And then, thirdly, just making for sure you've established as much of a rapport as you possibly can. This is a very delicate patient population. They have a lot of trust challenges with a multitude of providers. They get labeled as people who are drug addicts and, in some case, people that, people think less of, which is just terrible. And, but they're a very special patient population and they're incredibly thankful when you're able to make an impact.
Great. Those are great points. And I think, before I went to PA school, I did social work for patients living with drug addiction. And I think going back to that kind of self-medication that the addiction is treating and in the busyness of a hospital setting, it's hard to kind of step back a little bit and realize what adds up to a patient ending up in that situation. So I think you hit the nail on the head there. Tell me, I think the next thing that might be interesting is what's an unknown or little known fact on the topic you presented?
Yeah. This is something that you learn whenever you're getting your HF cert. But, not enough of us could get that, I think, is there are situations where a patient is going to have a falsely positive urine toxicity for amphetamines. And that might be because of a medicine that they're taking that is not an amphetamine-based medication. So mexiletine, those types of medicines and the anti-arrhythmic mexiletine can lead to a false positive urine toxicity for methamphetamine. So we see that sometimes, and I think it's important to have that distinction because you don't want your patient inappropriately labeled something else because that, once it's in the chart, it's in the chart, and it tends to, continue to be a thing until someone puts their investigator hat on and clears it up. So mexiletine will cause the false positive UTOC. Also, wellbutrin can at times as well. So kind of keeping those in mind. In some cases, patients in addiction medicine might leverage high dose wellbutrin in order to, deal with the cravings of amphetamine. So it's one of those things where you don't really know if they're truly still using amphetamines or if it's, just the medicine they're currently prescribed to help with that.
Oh gosh, those are great pearls that I sure didn't learn in PA school. So I'm really glad you brought that to the forefront. And this is a special population. You need to be keeping some of those in the back of your mind. Now, we talked a little bit offline, a little bit about that. Are there lots of new guidelines for this patient population, or what current guidelines can we apply to help our patients who are struggling with this addiction?
Yeah. There aren't a lot of specific, tailored guidelines for meth HF, Laura. And I think it's a huge area for opportunity in the future. And there's a lot of different corners in North America, focusing more on this because it is a huge problem, particularly on the West Coast where the supply of it is, through the roof. But I think the existing guidelines for HEP-REF are always a great place to start. Going to have everything you need to determine, what medicines would be a good place to pull the trigger on. And then secondarily, how are you going to monitor this patient in the weeks and months that follow? So I think getting NT-proBNPs, trending those, pulling the trigger on your 4 pillars, checking in with patients. I like to do it at least every 2 weeks just to make for sure we're not missing any opportunities to improve. And I think that's a great place to start. And then one last thing I talked about in our lecture was don't be afraid to order urine drug screens regularly. And when you do it, make for sure you're telling the patient you're doing that. Don't make them feel like you're trying to sneak around and catch them in a web of lies or something silly like that. Again, as I said previously, patients in this category have a lot of trust issues. And I think if they find that someone's trying to do something that might be perceived as underhanded, that's going to cause a negative outcome. So be honest, let them know you're going to order it and just explain to them, I'm ordering this because I care about you. I need to know where we're at in the ball game. And if it's negative, cool. Give them a thumbs up, give them a high five. If it's positive, then just reassure them we've got more work to do and we can plug you into the right specialties to get you the best help you need.
Oh, these are great points, Greg. And I should point out that you are co-chair of our heart failure committee. We're so happy to have you join the APAC board. And I heard you mention the heart failure certifications. You want to just touch on that briefly through HFSA?
Yeah, absolutely. HF Cert's something offered through HFSA, as you said. It's for people who have a pretty decent load of heart failure patients. I can't remember the exact hours required to sit for the exam, but the exam, it's a pretty comprehensive and, good way to prove your worth in the heart failure community. It's a good badge to kind of have as like someone who knows how to take care of heart failure patients in the appropriate way, how to titrate medicines effectively. And I just think it's worth everybody to get because it helps you prove what you already know. And then in some areas, it helps you kind of brush up on things that you may not be as familiar with. So just a great thing to pursue if you're working in heart failure.
Love that. I love that the HFSA recognize that we have these highly trained PAs and nurse practitioners who can really, showcase what we've learned and the care we deliver. I'll never forget one of my favorite cardiologists who long retired. I said he went into cardiology because there was one drug for heart failure called digoxin and one or two tests, an EKG and an echo. He's like, I can't believe how much more there is and how thankful the whole team is to have PAs like you treating heart failure. So great. Thank you so much. I hope you and all of our listeners and watchers will tune in for CAPP 2025. We'll be in the fall again. Stay tuned. We'll be releasing dates and locations shortly. Save that CME money and stay tuned for more APAC recaps. Thanks, Greg.
Yeah. Thank you so much, Laura. I appreciate it.